So let's begin. Hello everyone, welcome back to the series of lectures in nephrology. This is Dr. Maitri. Today we will be learning about acute kidney injury. So let us look at the definition of acute kidney injury. So acute kidney injury is basically defined as an impairment in kidney function which is expected or known to have occurred in less than 7 days. So an impairment in kidney function which is expected or known to have occurred in the past 7 days. Okay, so this is your basic definition of acute kidney injury. Now, as per the KDIGO, we have a separate set of staging of acute kidney injury. So this basically is dependent upon the creatinine as well as the urine output. The two previous staging systems which were used is your Akin as well as the rifle criteria. Right? So these are not used anymore. What we follow is your KDIGO staging of AKI. So stage 1 is basically when the serum creatinine is 1.5 to 1.9 times the baseline, or there has been an increase by more than 0.3 milligram per deciliter, or the urine output has been less than 0.5 ml per kg per hour for past 12 hours. Then stage 2 is when the creatinine is 2 to 2.9 times or 2 to 3 times the normal creatinine, and the urine output has been less than 0.5 ml per kg per hour for more than 12 hours. Stage 3 is when the creatinine is more than 3 times the baseline, or the increase in serum creatinine has been to more than 4 mg per deciliter, or the patient has to be initiated on renal replacement therapy. Then it is your AKI stage 3. And based on the urine output, it is urine output less than 0.3 mg per kg per hour for more than 24 hours. So the urine output is less than 0.3 mg per kg per hour for more than 24 hours. So this is about your staging of acute kidney injury. So staging of acute kidney injury is based on your serum creatinine as well as the urine output levels. So we understood what is stage 1, 2 and 3. Now let us understand the classification of AKI. So first points that you have to remember is that acute kidney injury is classified as your prerenal, intrinsic AKI and postrenal. Any acute kidney injury can be classified as prerenal, intrinsic AKI and postrenal AKI. So prerenal basically means what? Any condition which is associated with hypovolemia or decreased cardiac output. The patient is in some form of shock, right? So if the patient is in some form of shock, like because of hypovolemic shock, or the patient is in septic shock, or the patient is in your hemorrhagic shock. So in all of these conditions, finally the cardiac output is low, and we know that the renal blood flow is up almost 20% of the cardiac output, right? So if the kidney has to maintain its function, then you have to maintain the renal blood flow well. So any condition where the renal blood flow is impaired is your prerenal AKI. Apart from that, congestive heart failure, liver failure, or anything that impairs the autoregulation of the kidneys. We will be looking at the autoregulation of kidneys in some time. Alright, so this is your prerenal AKI. Now let us look at intrinsic AKI. Intrinsic AKI basically means that any disorder which is affecting the kidney in itself is what we call as the intrinsic AKI. So in this intrinsic AKI, it can be classified as multiple parts. So kidney is always divided into compartments. Kidney, whenever you speak of the disease of a kidney, you divide it in terms of compartments. So what are these compartments, right? So the compartments basically means which part of the kidney is affected. So intrinsic AKI can be because of a glomerular disease like glomerulonephritis. Okay. Then tubules and interstitium. So there can be diseases affecting the tubules and the interstitium and the vascular compartment of the kidney. So what are the causes for each? Under glomeruli, we have acute glomerulonephritis. Tubules and interstitium can be affected by ischemia. They can be affected by sepsis or infections, and endogenous or exogenous toxins, which we will be looking at in more details. Then diseases which affect the vasculature of the kidney, including vasculitis, malignant hypertension. Then postrenal AKI. Postrenal AKI is basically any disorder which causes obstruction. This is also called as obstructive AKI. So it can be because of bladder outlet obstruction. So any tumor, any stone in the bladder which can cause bladder outlet obstruction, there is an obstruction to the flow of urine, it can cause a postrenal AKI. Or it can be because of a unilateral or bilateral stones anywhere in the urethra or the uretropelvic junction. This can result in a postrenal AKI. Okay, so this is about the various types of acute kidney injury. So we have the prerenal, the intrinsic as well as the postrenal AKI. Okay, now let us look at each type of AKI in detail. So what are the mechanisms of prerenal AKI? Now I already told you that prerenal AKI is associated with what? It's associated with any form of hypovolemia or decreased renal flow, decreased renal blood flow. Right? So any form of hypovolemia or decreased renal blood flow is seen in prerenal AKI. So let us understand this certain autoregulatory mechanisms which are found in the kidney. So this is your glomerulus, and the vasculature of the kidney comprises of an afferent arteriole which goes into the glomerulus and an efferent arteriole. So this is your afferent arteriole, this is your efferent arteriole, right? So the main aim is that we know that the renal blood flow accounts for about 20% of the cardiac output. So to maintain the renal blood flow, what you have to do, you require dilatation of the afferent arteriole and constriction of the efferent arteriole. So dilatation of the afferent arteriole and constriction of the efferent arteriole is required when the blood flows through the glomerulus, it then gets filtered out. So this helps in maintaining the renal blood, right? So what are the molecules which help in this? So maintenance of the afferent arteriolar dilatation is brought about by prostaglandin I2, prostacyclin and nitric oxide, which act as dilators, which are vasodilators. So they help in dilatation of the afferent arteriole. Constriction of the efferent arteriole is brought about by which mediator? It is brought about by angiotensin II, as you can see here. Okay. So let us understand autoregulation. We have already understood the mediators. Angiotensin II helps in constriction of efferent arteriole. Prostaglandins help in dilatation of afferent arteriole. Okay. So this is about the different mediators involved. Then the second part of your autoregulation includes what is called as your myogenic reflux. So the second part of your autoregulation includes what is called as your myogenic reflux. So in this myogenic reflex, what happens is that, so whenever there is increased flow, the myogenic reflex identifies it and then it causes further dilatation of the arterioles and maintains the blood. Whenever there is a decreased flow, then what happens is that the myogenic reflex is activated and it will cause constriction of the afferent arteriole. Okay, so this dilatation, constriction in response to flow can be brought about by your myogenic reflex. So what is the meaning of this tubuloglomerular feedback? The third mechanism is your tubuloglomerular feedback. So what is the mechanism of this tubuloglomerular feedback? So whenever there is a decrease in the solute load, what happens? That means that the sodium delivery is decreased. When the sodium delivery is decreased, this causes stimulation of an organ which is called as the macula densa. The macula densa recognizes it. That means that it recognizes that there is a decreased blood flow, right? So when the solute load is decreased, that means there is a decreased blood flow. Then what happens? This means that there is a decreased blood flow. Then what will happen? In order to maintain the blood flow, it has to dilate the afferent artery, constrict the efferent artery, right? So this is how we have a tubuloglomerular feedback. So when the tubules sense that there is a decreased solute load, decreased sodium, this means that it senses it that there is a hypovolemia. So if there is a hypovolemia, this is sensed by the macula densa. Then what happens? This gives a feedback that there should be conservation of flow to the kidneys and there should be maintenance of the renal blood flow. Otherwise, there can be a renal shutdown. So these are the ways in which autoregulation is brought about. One is by the mediators, second is by your myogenic reflex, and third is by your tubuloglomerular feedback. Fine? So let us understand how certain drugs affect these mediators and how it causes prerenal AKI. So let us understand NSAIDs, right? So what happens in NSAIDs? NSAIDs are the one which basically inhibit the prostaglandins. So what happens is that there is a decrease in the vasodilatory prostaglandins and prostacyclins which are responsible for keeping the afferent arteriole dilated. So this will cause constriction of the afferent arteriole. Then if there is constriction of the afferent arteriole, what happens to the GFR? The GFR begins to fall. Similarly, if you give ACE and ARBs, ACE and ARBs inhibit angiotensin. Angiotensin is mainly responsible for constriction of the efferent arteriole. If you give that, what happens? There will be dilatation of the efferent arteriole. There is dilatation of the efferent arteriole and hence the GFR begins to fall. So it's not that every NSAID and every ACE-ARB is going to cause AKI, but if the patient is already compromised, like if the patient is already in shock or if the patient is already in a hypovolemic state, when you give NSAIDs, when you give ACE-ARB, there is impairment in the autoregulation in the kidney and hence you can have a prerenal AKI. So this is about the mechanisms of prerenal AKI. So you have understood till here what is AKI. We have learnt about the KDIGO staging of AKI. We have learnt about what is prerenal AKI. We have learnt the mechanisms of autoregulation and we have learnt about the mechanisms of autoregulation and how these drugs affect that. Now, let us understand what is your prerenal AKI versus renal AKI. So, how is your prerenal AKI different from your intrinsic AKI? Or what are the tests that you want to do for these? Right? So, in prerenal AKI, the hallmark feature in your prerenal AKI is your BU by plasma creatinine ratio. The BUN by plasma creatinine ratio is more than 20:1 in prerenal. So always whenever you see a patient with acute kidney injury, look at the BU creat ratio. So if the BU creat ratio is more than 20:1, then this is a prerenal cause. If it is 10 to 15:1, then you have to think of intrinsic AKI. What are the causes for intrinsic AKI? We have discussed, we will discuss further as well. You look at the urine sodium. Urine sodium is less than 20. Here the urine sodium is more than 40 in renal failure, in intrinsic AKI, because the tubules are lost. So the concentrating capacity of the tubules is lost and the sodium is lost in the urine. Right? Then we see that the urine osmolality is more than 500. Why? Because the patient is dehydrated. If the patient is hypovolemic, you will have a concentrated urine. Whereas here in oliguric renal intrinsic AKI, the urine osmolality is lower. Then we have something called as the fractional excretion of sodium. So this is given by the formula urine sodium into plasma creatinine by urine creatinine into plasma sodium. So the FeNa is again less than 1. So you remember that the urine sodium as well as the FeNa go hand in hand. And the FeNa is more than 2% in oliguric AKI. Because the tubules are damaged, the sodium excretion is more. Then just remember this odd point that the urine by plasma creatinine ratio is high. So this is the only odd point here. It is high in prerenal AKI, but it is less than 20 in intrinsic AKI. What type of casts are seen? You get a hyaline cast in prerenal, you get a muddy brown cast in your intrinsic AKI. So the major important differences you have to remember. If you understand the mechanism of prerenal versus renal AKI, you will understand this as well. So in prerenal AKI, look at the BUN creat ratio, it is always higher. What happens to the FeNa in prerenal AKI? The FeNa will be less than 1%, but it is elevated more than 2% in intrinsic AKI. What is the type of cast you get? You get a hyaline cast in prerenal AKI, you get a muddy brown cast in intrinsic AKI. Okay, this is about the most important clinical differences between prerenal as well as your intrinsic AKI. Okay, now we have learnt about prerenal and prerenal versus intrinsic. Let us go into the different types of intrinsic AKI. So, like we have discussed already, whenever you talk about the intrinsic AKI, you always discuss the kidneys in terms of compartments. So, glomerulus, if the glomerulus is affected, what kind of disorders? It is your glomerulonephritis. Tubules, how are the tubules affected? How can the tubules be affected? It can be due to exogenous substances like contrast. Where do we give contrast? So where do we give contrast? You know that we give it in certain contrast CTs, right? So contrast in itself can precipitate in the tubules and cause AKI. Apart from that, it can be due to drugs like cisplatin. Then tubules can be damaged because of endogenous toxins. Tubules can be damaged because of endogenous toxins, which can be due to hemolysis, multiple myeloma, uric acid crystals, which you see in tumor lysis syndrome. Excessive uric acid is seen in tumor lysis syndrome. Apart from that, you have ischemic ATN and septic ATN. ATN stands for acute tubular necrosis. Ischemic ATN and septic ATN. Then we move to the interstitial compartment. So what are the things which can cause damage to the interstitium? Allergic interstitial nephritis secondary to drugs such as proton pump inhibitors and NSAIDs. Infections like Legionella. Infiltrations like myeloma itself is an infiltrative process. Inflammatory conditions like Sjogren's and even sepsis. Vascular compartment of the kidney associated AKI can be due to HUS, TTP, which is your thrombotic thrombocytopenic purpura, DIC, atheroembolic diseases and even hypertension. So this is in broad about the various causes of AKI and how each compartment can be affected by it. Before we move on to the different types of AKI and different causes of AKI, let us understand how these urinary sediments help in the diagnosis of AKI. So, first thing is that you can have some form of CAS, which is nothing but urine proteins along with blood, along with WBCs and so on and so forth, right? So, this can result in CAS. So, in prerenal or postrenal AKI, you have something called as your hyaline CAS. Apart from that, some forms of HUS-TTP, also you can have hyaline CAS. Then, RBC CAS. RBC CAS basically means that you have RBCs along with urinary proteins which are excreted. So, the moment you have an RBC CAS, the first thing that you have to think of is your glomerulonephritis. Apart from this, what are the other conditions which can be associated with an RBC CAS? You have vasculitis, malignant hypertension and TMA. You have vasculitis, malignant hypertension and TMA. WBC CAS. So, WBC is in the urine. Pyuria, you know that from your basic understanding in UTIs and pyelonephritis, you can have WBC CAS. But every time a WBC in the urine, it is not always an infection. So, there are certain other conditions where you can have WBC CAS. It is seen in interstitial nephritis, some forms of glomerulonephritis, allograft rejection, or myelomatous infiltration of the kidney. All of these can be associated with a WBC CAS. Then, let us see epithelial CAS, which is seen in acute tubular necrosis or ATIN. Granular CAS can be seen in ATN, glomerulonephritis or tubulointerstitial diseases. Eosinophiluria. When do you find eosinophils in the urine? You can find it in allergic interstitial nephritis. So, it's very, very important. Allergic interstitial nephritis, atheroembolic disease, pyelonephritis, glomerulonephritis. So, allergic interstitial nephritis, atheroembolic disease, pyelonephritis, glomerulonephritis, all of these are causes of eosinophiluria. Crystals. When do you find crystals? Uric acid nephropathy in tumor lysis syndrome. Certain drugs can also crystallize in the tubules and you will have crystalluria like indinavir, amoxicillin and so on. Okay. So, this is about the analysis of urinary sediments in AKI. Now, let us go to acute tubular necrosis. Now, in this, what we are going to learn is we are going to understand how each cause for acute tubular necrosis presents. How do you analyze the patient, what are the tests you will do and what is the treatment. Okay, so this is what we will be looking at. The first and the most common cause is your septic ATN, right? In your septic ATN. So, in a patient of sepsis, how will the patient present to you? So, in a patient with AKI, if you are considering sepsis, what all will you think of? Patient with fever, patient with shock, and what is the investigation that will be positive, right? It will be a blood culture. So, a blood culture will be positive. What is the aim of the blood culture? It is used to find out the focus of the infection. So, whether this is a urinary tract infection which is causing the sepsis, or is it because maybe like an endocarditis which is causing the sepsis, or is it because of an abscess which is causing the sepsis, right? So, for these reasons, we have to do a urine culture, blood culture, find out what the sepsis is due to. Now, what are the other clues in investigations? You will have granular CAS, you can have WBC CAS as well. What happens to the fractional excretion of sodium? We have learned that in any intrinsic AKI, most often in intrinsic AKI, you will have a FeNa of more than 2%, right? And how do you treat this AKI? So, this AKI is responsive to fluids, it is responsible to antibiotics. right? Septic AKI can be prerenal also, because they can have septic shock, they can have hypovolemia, hypoperfusion, they can have prerenal AKI also. So IV fluids along with antibiotics is the treatment for septic ATN. Okay. Then, so the second type is your ischemic acute tubular necrosis. So in this ischemic ATN, what happens is that there is ischemia, as the name suggests, there is a decreased blood flow, which is the site which is most vulnerable to ischemia. So the most common site is it is the S3 segment of the proximal convoluted tubule, and the site is the outer medulla. So when do you have ischemic ATN? In severe shock. In severe shock, you can have ischemic ATN. So how will you identify this? In a patient with shock, the urine can show muddy brown cast, similar to your other forms of intrinsic AKI. The FeNa can be high, and you look at the urine specific gravity. SG basically refers to urine specific gravity. So this urine specific gravity has a value which is 1.010. This is basically because the tubules have lost their capacity to reabsorb the solutes, and this is what we call as your isostenuria. This is what we call as your isostenuria. Okay. So the presence of isostenuria, muddy brown cast, and in the background of this kind of a clinical scenario, you have to suspect ischemic ATN. Now, let us look at the next type, which is your contrast-induced AKI. So, what is this contrast-induced AKI? In our previous discussion, we have understood that contrast is basically used in many diagnostic scans. It is used in performance of maybe a CECT, which is your contrast-enhanced CT, and so on. Contrast can also be used in another procedure, especially in cardiology, which is your coronary angiogram, right? So the use of contrast in any of this can result in an AKI. So a high volume, high osmolar ionic contrast, this is the one which has the highest propensity to cause contrast-induced AKI. So this contrast-induced AKI, the creatinine starts to rise by 24 to 48 hours. It peaks by 3 to 5 days and it normalizes by 7 to 10 days. So, contrast-induced AKI is similar to a prerenal AKI. So, it has a low FeNa. And what is the treatment? What is the treatment? For treatment of contrast-induced AKI, till now, as per the guidelines, it is only hydration. So, you start IV fluids 24 to 48 hours before any procedure, before any scan or before any procedure like your angiogram, and you continue it for another 48 hours after the procedure as well. So good amount of hydration is the only preventive method which has been proven, and some centers also use N-acetylcysteine. But N-acetylcysteine and its use in contrast-induced AKI has not been proven completely. It has not been proven completely, and hence N-acetylcysteine may or may not be used. Many centers use it. So this is about your contrast-induced AKI. Now let us look at the next disease. The next disease is your atheroembolic renal disease. Now how does your atheroembolic renal disease present? So following an intervention or lysis, in a patient who has severe atherosclerosis, so in a patient who has severe atherosclerosis following an intervention, so you do a thrombolysis or you go and put in a stent, what happens is that he can develop an acute to subacute renal failure. So this renal failure is your atheroembolic disease. So the atherosclerotic plaque which is present in one of the vessels can travel through the vessels and go and block your renal vessels, right? So the triad is subacute renal failure, and the hallmark skin changes which are seen is that the hallmark skin changes which are seen is this lacy pattern on the skin, a lacy pattern on the skin, and this is what we call as the livedo reticularis. This is what we call as the livedo reticularis. And then in the eyes, in the retina, you can find these kind of phlovoids, which is because of these plaques. The atheroemboli go and lodge in the retina as well, and this is what we call as the Hollenhurst plaque, right? So the triad of subacute renal failure with livedo reticularis and the presence of Hollenhurst plaque is the characteristic feature of atheroembolic disease. Okay. So how do you diagnose this? Of course, you have this clinical criteria. Apart from this, urine analysis can show eosinophilia, eosinophiliuria, right? You can have raised ESR and CRP and low complements. On the biopsy, if you do a biopsy, if this is your vessel or if this is your kidney, you can have something called as cholesterol clefts. On the renal biopsy. Raised ESR, CRP, eosinophilia, eosinophiliuria and cholesterol clefts on the kidney biopsy. So what is the treatment? Most often it is conservative. ACE inhibitors can be used in the treatment of atheroembolic disease. Alright, now let us look at the next cause of intrinsic AKI, which is your tumor lysis syndrome. So what happens in tumor lysis syndrome? So as the name suggests, in tumor lysis syndrome, there is tubular obstruction, right? Obstruction by what? Obstruction by uric acid. So whenever there is high tumor burden in the body because of a hematological disorder, a hematological tumor most often, sometimes even in solid organ malignancies, the tumor cells begin to rise. As the tumor cells begin to rise, the uric acid goes on rising and the uric acid causes obstruction in the DCT and in the collecting duct, and it causes a form of oliguric renal failure, which is called as tumor lysis syndrome, and this is one of the most important oncologic emergencies. So how do you diagnose it? There is hyperkalemia. All of it is hyper. There is only one thing that you have to remember, which is hypo. Okay, hyperkalemia, hypermagnesemia, hyperphosphatemia, hyperuricemia. Calcium is the only one which is hypocalcemia. So the only one which is hypocalcemia is your calcium, right? It's hypo. How do you treat? The cornerstone management tumor lysis syndrome is IV hydration. You have to hydrate the patient well. Apart from that, what is the basic thing which is getting obstructed which is obstructing the tubules? It is your uric acid, right? So you have to inhibit this uric acid. So this can be brought about by allopurinol or rasburicase, which are drugs which are used to bring down the uric acid levels. But these are only temporary measures, right? Most of the cases of tumor lysis syndrome, you have to undergo hemodialysis. Alright. So this is about your tumor lysis syndrome. Now let us understand rhabdomyolysis. So we have heard this term rhabdomyolysis multiple times prior. What is rhabdomyolysis? As the name suggests, it is myolysis. So there is breakdown of the muscle. With the breakdown of the muscle, there can be excretion of potassium and there is hyperkalemia. So what are the causes for which they can be a rhabdomyolysis? It can be because of severe exercise, seizures, electric shock, crush injury. We have learned that metabolic disorders, the major metabolic disorders like hypokalemia, hypophosphatemia, all of these can cause rhabdomyolysis. Alright, then genetic conditions and drugs like cocaine, alcohol and statins can also cause rhabdomyolysis. So how does the patient present? What are the clinical features? They present with severe muscle pains, oliguria and high colored urine, and of course elevated potassium. How do you diagnose it? The cornerstone test that we do is your creatinine phosphokinase. The creatinine phosphokinase or elevated CPK levels basically mean that there is a problem with the muscles. Apart from that, the ALT levels will also be elevated because we know that there is muscle ALT. Whenever there is muscle damage, ALT can go up and the potassium is also elevated. Right? So in the background of this clinical scenario, with this kind of a picture, you have to think of rhabdomyolysis as the cause of AKI. So how do you treat it? Again, the cornerstone management is hydration. Then you can do alkalinization of the urine, and the final management will be using hemodialysis to remove the potassium. Alright, now let us move on to the next set in the causes of intrinsic AKI. The next group of disorders that we should be aware of is your multiple myeloma. Now, multiple myeloma can cause prerenal, it can cause renal AKI or intrinsic AKI as well. So how does multiple myeloma cause prerenal AKI? To understand that, let us understand the basics of multiple myeloma. So what is multiple myeloma? This is a hematologic malignancy. So what is multiple myeloma? This is a hematologic malignancy, right? So what happens here is that there is plasma cell infiltration into the bone marrow. There is an increase in the plasma cell infiltration in the bone marrow, and these cells produce light chains. These cells produce light chains, and these light chains are the one which can damage the kidney. So this is the basic fundamental principle that you should be aware of, right? So what are the associations of multiple myeloma? So you would have remembered something called as CRAB. You will be knowing of something called as CRAB. So what is CRAB in multiple myeloma? It is hypercalcemia, renal failure, anemia, and bone pains. So how does a multiple myeloma patient present? Before they present with this CRAB symptoms is a full-blown myeloma. They can have fatigue, they can have bone pains, they can have anemia, renal failure, raised ESR, one of the very few causes of raised ESR beyond 100, right? Along with osteolytic bony lesions and hypercalcemia. Okay. So what are the mechanisms of renal injury in multiple myeloma? In prerenal hypercalcemia in itself can cause prerenal AKI. Okay. Next, use of NSAIDs. Because many of these myeloma patients have a lot of bony pains, they tend to abuse NSAIDs, and that is the reason why use of NSAIDs can cause prerenal AKI in myeloma patients. The other mechanisms of AKI in myeloma patients include light chain cast nephropathy. So what is this light chain cast nephropathy? There is production of huge amounts of light chains. These light chains then go and obstruct the tubules. When these light chains go and obstruct the tubules, they can cause something called as light chain cast nephropathy. Apart from that, they can cause proximal RTA, renal tubular acidosis, and amyloidosis. So these are the various ways in which multiple myeloma can affect the kidney. So how do you diagnose it? We diagnose it with the help of these CRAB features that we have told. We have to do a bone marrow and show that there is evidence of plasma cell dyscrasia, and blood tests which are used include your serum protein electrophoresis and serum free light chain analysis. So serum protein electrophoresis and serum free light chain analysis. So all of these can be used in the diagnosis of multiple myeloma. Lastly, when it comes to intrinsic AKI, let us understand how different types of antibiotics cause intrinsic AKI. So vancomycin causes intratubular obstruction. Aminoglycosides and amphotericin B cause tubular necrosis. And remember that these cause tubular necrosis, so they can have hyponatremia, they can have hypokalemia as well, and hypomagnesemia. So magnesium, potassium, all of these are affected with this group of drugs, and they continue to remain non-oliguric. So this results in a non-oliguric AKI. Acyclovir causes tubular obstruction. Then bevacizumab is an anti-cancer drug which causes thrombotic microangiopathy. It causes thrombotic microangiopathy. Okay, fine. So this is about the various causes for intrinsic AKI. We have understood how the patient will present, what are the mechanisms, how will you diagnose and treat each type. Alright, fine. Let us understand a separate entity which is called as cardiorenal syndromes. So cardiorenal syndromes is also another very important etiology for acute kidney injury, right? So this is divided into 5 types. Let us understand each. Type 1 basically stands for acute cardiorenal syndrome. What is the meaning of this? So in type 1, you basically have the acute cardiorenal syndrome, which basically means that an acute cardiac condition is causing renal dysfunction, which means that an MI causing renal dysfunction or a heart failure causing renal dysfunction is your acute type 1 cardiorenal syndrome. Type 2 is your chronic cardiorenal syndrome. Any chronic cardiac condition causing renal dysfunction, like your congestive cardiac failure which has been there over a chronic time. So chronic condition causing chronic cardiorenal syndrome. Then type 3 is your acute renocardiac. Acute renal failure causing heart failure is your acute renocardiac syndrome, right? Type 4 is your chronic renocardiac. Chronic renal failure can cause heart failure as well. It causes LVH, it causes systemic hypertension and heart failure. Then type 5 is when renal and cardiac diseases are present simultaneously, and each of them cause cardiac and renal failure separately. So this is about your cardiorenal syndrome. Alright. So till here we have understood about the various causes of intrinsic AKI. Especially we have dealt with the tubular component. right? Glomerular disorders we will be dealing separately. Vascular disorders of the kidney we will be dealing with separately. Now, after understanding the different types of prerenal AKI, causes for prerenal AKI, different etiologies for tubular causes of intrinsic AKI, let us understand how interstitial compartment can be affected. So, we are dealing with allergic interstitial nephritis. So, allergic interstitial nephritis basically presents with a triad of clinical features. So, what is the triad of clinical features in which this allergic interstitial nephritis presents? So, it presents with a triad of fever, oliguric kidney injury and eosinophilia. Where else have we seen eosinophilia, right? So, eosinophilia is also seen in chronic interstitial nephritis, okay? And eosinophilia is also seen in atherosclerotic disease. So, it comprises of a triad of clinical features which includes fever, oliguric kidney injury and eosinophilia, okay? So, what are the most important etiologies for your allergic interstitial nephritis? So, first most importantly, antibiotics, vancomycin, beta-lactam antibiotics, quinolones, linezolid, acyclovir, right? So, all of these can cause allergic interstitial nephritis. Then, NSAID, right? Diuretics, very important. Then, anticonvulsants including phenytoin, carbamazepine. Then, PPI, one of the most abused drugs. You give PPI for everything, but remember PPI has a high risk for allergic interstitial nephritis. Then infections like bacteria, strep, staph, salmonella, brucella, viral infections and leptospira. Autoimmune disorders like SLE, Sjogren's, sarcoid, IgG4. Metabolic diseases including hypercalcemia, hyperphosphatemia, hypokalemia, hyperuricemia. Everything is hyper. Remember, hypokalemia itself can cause allergic interstitial nephritis. Then polycystic kidney disease and chronic UTI, right? So, this is about the various etiologies for allergic interstitial nephritis. So, when does this AIN present? So, does this AIN present immediately after you give an offending agent or immediately after an infection? No, it presents with this triad about 5 to 7 days after an inciting event. Apart from this, you can also have rash, right? You can also have rash. So, in any of these patients who present with this kind of an AKI, if you are suspecting AIN, please take a thorough drug history. Many times there are most of these drugs, in fact, if you see in this list, you give NSAIDs, you give diuretics, PPI so often, right? So, many times diuretic induced AKI, you think it is prerenal. No. If they have a rash, if they are developing new onset fever, eosinophilia, always think of AIN as well, right? So, it usually takes about 5 to 7 days. It can happen slightly earlier as well. So, this is a huge list of the etiologies of AIN that you have to remember. Fine. Now, how do you diagnose AIN? How do you diagnose AIN? So, the most important thing is your window to your kidney is your urine analysis. So, in your urine analysis, you look for pyuria. Like I told you, all pyuria is not infection. It can be AIN also. Then you look for WBC cast. You look for hematuria. Okay. Then, you have to do a renal biopsy. You do a renal biopsy if the diagnosis is not clear. If the diagnosis is not clear, then you have to biopsy the kidney and do it for analysis. So, if you can see here, I will enlarge it for you. These are the tubules. This is your interstitial compartment. Can you see that there is infiltration? There is infiltration by a large number of WBCs, plasma cells, right? There is the infiltration by large number of WBCs, plasma cells, especially neutrophils, mainly because of, it's an allergic reaction, right? It's an allergic reaction to any of these offending agents. So, this is what you will see in your renal biopsy. The glomerulus, the tubules will be normal, the interstitium will be inflammatory. Okay, fine. So, what is the management? Most importantly, if it is a drug, you remove the offending agent, right? Wait and watch. You give supportive measures. If there is hypertension, you give ACE-ARB. If there is proteinuria, you give ACE-ARB, right? You hydrate them well. Watch out for the volume status, right? You make sure that the urine output is maintained. And you give some supportive measures throughout. So, the moment you take off the offending agent, you wait and watch and do your conservative measures. But many a times, despite 1 week, if you are having rapid progression of the disease, you have to give corticosteroids to bring down the inflammation. Also, in many cases of AIN, which is associated with Autoimmune disorders like how we had seen, which is your Sjogren's or sarcoid or IgG4, then you directly give upfront steroids. Right? So this is about your AIN, your allergic interstitial nephritis. Okay. So till now we have understood about the various etiologies of AKI. Now let us move forward to the management of acute kidney injury. So management includes evaluation as well as treatment. So in the evaluation, what you have to do, you definitely have to do your renal failure indices. You have to monitor your creatinine every day. You have to monitor your serum electrolytes every day. Right? You monitor your creatinine, you monitor your serum electrolytes every day. Apart from that, you can do a radiological assessment. So apart from this, you also need your bun. Don't forget your bun, because you have to find out whether this is a prerenal or a renal AKI. Okay. You can also use a FeNa to differentiate whether this is your prerenal or your renal AKI. Then you go on to your radiology. What is the use of your ultrasound in AKI? So ultrasound can be used so that it helps in differentiating from CKD. How? Because in chronic kidney disease, if any injury has been happening for a longer time, then you can have shrunken kidneys. Then the corticomedullary differentiation is lost. So this is how ultrasound can help. Also, you can find out the etiology. In prerenal renal AKI, you cannot find out much. But in postrenal AKI, you can find if there are renal stones. If there are tumors, if there is evidence of any pyelonephritis, right? So all of these you can find out using your radiology. Then, what is the use of CT-KUB? This again can be used in your postrenal. You can find renal stones, you can find evidence of pyelonephritis as well. Then what is the use of Doppler? If you are suspecting a disease which is affecting the vascular compartment of the kidney, right? So, for example, in renal artery stenosis, or it can be because of some form of thrombotic microangiopathy or anything of that sort, you can use it. You can find out the cause for the AKI using a Doppler. Then, what is the role of renal biopsy? A renal biopsy is very, very important in glomerular diseases. Apart from that, in certain cases of interstitial nephritis as well. Right? So before you even do all of this, be very, very clear and thorough with your history and physical examination, because you have to find out, is this an infection or is this a drug? Be very thorough with your drug list and then only go ahead and do all these investigations to find out what is the etiology of AKI. Then there are certain newer molecules which are used in diagnostics, which includes your NGAL, which is your neutrophil galactosidase. Then you have your SUPAR and IGF-BP7 and TIM2, which are found to be most specific, and interleukin 18. So these are some of the newer molecules which are used in the diagnosis of AKI. Now we come to the management. So when it comes to the management of AKI, we have to look at each complication separately. So the first complication is uremia. You know that the moment there is an acute kidney injury, the kidney slightly begins to shut down, the toxins are not going to be excreted. As the toxins start accumulating, you can start having uremia. So whenever there is uremia, it is an indication for hemodialysis. Uremia can be managed slightly. You can manage uremia to a certain extent with conservative measures, but if there is uremia, the most definitive treatment is with hemodialysis. Then volume status. You have to be very careful with IV fluids, because if you give IV fluids to a higher extent, then they can develop edema, right? They can go into pulmonary edema because the renal functions are not quite good. So be very careful with IV fluids. Also make sure that they are well hydrated, okay? And you make sure that the urine output is good. Urine output is more than 1 ml per kg per hour. Then electrolytes. What are all the electrolytes that you have to be looking at? Sodium. Most often sodium disorders are not seen in AKI. It can be seen only in tubular dysfunction. In tubular dysfunction, you can have a transient hyponatremia. In tubular dysfunction, you can have a transient hyponatremia, and this transient hyponatremia need not be corrected unless they are symptomatic. Most often it recovers, right? So sodium disorders are not quite common. You can have hyperkalemia. You can have hyperkalemia. Management of hyperkalemia we have already discussed. So one can be administration of calcium gluconate so that you maintain the cardiac myocytes. It becomes a cardiac stabilizer. Then you can give certain drugs which help in the transcellular shift like insulin in dextrose or nebulization salbutamol or beta agonist, right? Apart from that, you can also give potassium binders. So you will have to manage a hyperkalemia, as in when it comes refractory hyperkalemia, you will have to dialyze the patient. Then in other forms of tubular injury, you can also have decreased magnesium and decreased potassium, which also recover with treatment. Fine. Then the next acid-base disorder that you can have is your metabolic acidosis. The next acid-base disorder is your metabolic acidosis. So you can give IV bicarbonate. You can give oral or IV bicarbonate in the initial stages where in cases of metabolic acidosis. But in the later stages, you may have to dialyze the patient. You may have to dialyze the patient. Then always take care of the nutrition. Always take care of the nutrition, especially the protein intake. Always take care of the nutrition in any patient because AKI can be a catabolic state, right? So protein intake should be around 0.8 to 1 gram per kg. So the protein intake should be around 0.8 to 1 gram per kg in a non-hemodialysis patient. If the patient is on RRT, it can go to 1 to 1.5 grams per kg. So take care of the nutrition as well, right? So this brings us to the end of our discussion on AKI. We have understood what is AKI, approach to AKI, staging of AKI. We have looked at the various etiologies of acute kidney injury, and we have looked at the broad management of acute kidney injury. In the next session, we will be discussing about chronic kidney disease, and we also have separate sessions for the different types of disorders which affect the vascular compartment of the kidney as well as the glomerular disorders. So I hope you have understood this session well. Meet you all in the next one. Thank you.